Hi, my name's Jo Gibson. Until very recently, I was a clinical physiotherapy specialist working at the Liverpool Upper Limb Unit, and I'm also an upper limb rehabilitation specialist working at Rehab for Performance. I like to pop onto Facebook on a Monday in conjunction with Clinical Edge to talk about all things shoulders, to share some interesting cases, and importantly, some useful clinical tips and tricks. Now, tonight, the theme is all about AC joint injuries. On Friday, I was lecturing at a shoulder conference, which was fantastic with some really respected colleagues in the shoulder and elbow world. And my talk was all about AC joint injuries. And it's ironic when you're preparing a talk like that, that actually suddenly you seem to see lots of people with the same pathology in a very short period of time. So I had a young guy who came in to see me. He was 24. He is a goalkeeper. He plays at a reasonable level, kind of in the National League. He'd had a fairly classic injury where he'd fallen onto the point of his shoulder. He'd got swelling. He'd got local tenderness. It was very painful at the time of injury and continued to be very painful for the first few days, such that he went to casualty. They did an x-ray and told him that he'd got a grade 2 AC joint injury. And essentially, he's been sent to me because the team are desperate to get him back to play because they're seriously close to being in the playoffs. And as you know, in sport, he's their top guy. Their second goalie perhaps isn't so good. And so they're very, very keen to have him back in the squad. Now, they've looked at the literature. It says that potentially he could be back in 10 days. And so really what they want to do is make sure they're doing all the right things for him. So where does that leave us? Well, the first question is, in somebody like this, what guides decision making? So he's had an x-ray that says he's got a grade 2. He's had a fairly typical injury, and I'm sure you remember the two most common mechanisms for AC joint instability. The first is if somebody falls onto the point of their shoulder with the arm in cross adduction. So essentially it hits the acromion. And then equally we can have that indirect injury where they fall on an outstretched hand and the humerus basically takes the acromion with it. So two common mechanisms. The direct is by far the most common. Now, this guy, when I see him, has got okay range up to about 95 degrees of elevation, limited by pain. Cross adduction is really painful in that he really doesn't want to go there. He certainly can't get across midline. He can't lie on that shoulder at night. He's not taking any medications at the moment. Now, as I say, we talked about the classic mechanism, but one of the most important things to know is that classification based on x-ray is notoriously unreliable. We originally had the TOSI classification, which essentially was just 1, 2 and 3. The first essentially was just a sprain of the ligament with no clinical deformity and looked pretty normal on x-ray. The second was where you had more than 25%. So if you looked at the position of the clavicle relative to the acromion, you kind of got a shift of about 25%, and those injuries correlated with actual damage of the AC joint ligaments. And then number 3 basically was anywhere between 25 and 100% on an x-ray in terms of how far that clavicle had gone relative to the acromion. Now, there's been lots of other attempts at classification, but essentially there was the Altman as well. But Rotwood essentially is probably the most quoted. Now, Rotman looks at 6 different subclassifications, which are basically based on increasing injury to the AC and coracoclavicular ligaments. Now, in a type 1, it's just a sprain of the AC joint ligament. In a type 2, you actually get a tear of the AC joint ligament. And again, we look at the relative deformity on an x-ray in terms of that 25%, or if like where it is in relation to the depth of the acromion compared to the clavicle. Then we get our type 3s, which is where we get injury to not only the AC joint capsule and ligaments, but also the coracoclavicular ligaments. And then our 4, 5, and 6 really relate to sequence of injury, if you like, to the deltoid trapezial fascia as it pulls off the clavicle. Now, it's really important to know when we look at that 4, 5, and 6, really that's just determined by which direction the clavicle goes. In a type 4, it goes posteriorly. In a type 5, it goes superiorly, and they're the ones that often might tent the skin. And a type 6, which I've never seen, which comes under the conjoined tendon. Now, that sounds great, doesn't it? The problem with the Rockwood classification is there is very poor intertester reliability when you look at studies. And the other thing is there's lots of different X-ray views that have attempted to improve its reliability. Rockwood classification is clearly very 2D or two-dimensional because in its very essence, it is based on the radiology or the X-ray itself. Now, the problem is that when you look at MRI, it disagrees in 50% of cases in terms of where that patient sits in that classification system. Now, that's certainly based on normal APs. We've got Zanker views where they angle the X-ray about 15 degrees cephalad, so up to the head, to get a better view of the AC joint. We've also seen the trend in weighted views, if you like, but again, they don't seem to have any superior benefit. We've seen the axillary view, which is meant to be good for picking up tight fours because it can see when that clavicle's gone posteriorly, but again, it's not infallible. And then finally, the fantastically named Basmania view, which essentially looks at when you take somebody into cross adduction, if it's unstable, you'll get overriding of the clavicle on the acromion. Now, as I say, the problem is irrespective of which X-ray view you use, none have shown superiority and importantly continue to disagree with MRI. So if you look at MRI, essentially it disagrees 50% of the time. In 30%, MRI will show that X-ray has overestimated, had to get that the right way round, overestimated the severity of the injury, and in 15% 35% overestimated and 15% underestimated the severity. So as you can see, in terms of treatment options and using that, particularly if we've got maybe somebody who wants to get back to high level sport, those things are very important to consider. Now, in terms of our clinical tests, guys, in instability, actually, we have very little evidence to look at the reliability of tests. We've got a couple that say if tests remain very painful over a period of time, it may be predictive of patients that do less well. But if we're honest, the methodology in those studies is pretty poor. We have the piano key test where you compare, literally, if you put your fingers on the clavicle and bounce it up and down and compare it to the other side, can you feel a key difference in terms of mobility, i.e. is there more mobility consistent with some damage to those ligamentous structures? Now, as I say, again, I struggled to find any kind of reliability data looking at that test. Now, what we do know with the AC joint, if you've injured it, if it hurts when you prod it, it hurts locally when you do cross adduction or you try and elevate, or even if you abduct, then that seems to be consistent with some local pathology. But we've got to be honest, the mechanism, as we've said several times in these different Facebook Lives, our subjective is 80% of our decision making. Now, the good news is if we look at our AC joint injuries, then up to 80% of them will improve by the 6-week mark. So certainly the majority of injuries that we see are in that type 1 and 2 camp. But remember, we have to be cautious interpreting the evidence when it's based on that Rockwood classification. Now, again, some of the evidence would suggest that our low-grade injuries, those type 1 and 2, should just be encouraged to do range of movement exercise, get back to their sport, and they can expect to do that anywhere between 1 and 6 weeks, with most people returning within 2 to 4 weeks. Now, as I said, there was one study that suggested it could be as quick as 10 days in a young athletic cohort. Now, the problem for us clinically is how do you decide? So with those threes, any of you that treat shoulders regularly will know there's huge controversy within that type 3 group. So where they've damaged the AC joint capsule and ligaments and the coracoclavicular ligaments, and may have some mild damage to the trapezial or deltoid trapezial fascia. But how can we decide those patients that are likely to do well? We can just take a punt and start treating them, but is there anything else that helps? Well, the fabulous Len Funk came up with this lovely idea of the locked and shocked scapula, and we also had a consensus document that along a similar line looked at whether things were painful and not, or stable or not. And if we combine those things, the locked, if you like, the locked unstable AC joint instability is when somebody has a limitation of range because that clavicle is overriding the acromion, and so it actually blocks their movement in later degrees of range. So that's a locked. The shocked is our type 3s, where again you've damaged those ligaments, so you can imagine the whole system's a bit shocked. But what's interesting is some patients can compensate really well with a good muscle system, whereas others can't. And what's not clear from the literature in terms of structural damage is what actually dictates that or not. Now, because of this, what most surgeons and most consensus documents will suggest is that you obviously assess them the first time you see them in terms of the amount of deformity. You might send them to have an MR scan, particularly if surgery is potentially in the offing. You reassess them at 3 weeks. If they're improving, you keep doing rehab. If they're not improving, they're not coping, and they've still got significant symptoms, then you would have a lower threshold to operate in a sporting population. If it's somebody who's not returning to sport, then potentially you might leave that for longer. Now, some of that relates to surgical preference, because if you look at the different devices that they can use to actually augment a ligamentous repair in somebody who's had AC joint instability, clearly they do it in that early stage. Some of the devices they use are designed so that there is some capacity for healing of the ligaments, and they're almost like a mesh, so that we can get ingrowth and vascular ingrowth into those structures. So that may weigh up a surgeon's surgical decision making. But a really important point to say is, if you delay it 6 weeks or actually even longer, actually it doesn't seem to negatively impact the outcomes in these patients. The new devices like the Lars ligament, the Infinity Lock, Dock and Bones, all these fantastic, there's a Kite one now as well. But the bottom line is the load to failure of these devices is actually greater than the ligaments themselves. So, and as I say, the great thing is delay doesn't seem to massively negatively affect things. The only issue with surgery is often it will get people back quicker because it's like an internal fixation. Now, going back to our patient, there's a couple of things that we need to consider. Let's say we've got a surgeon who wants us to do our 3 weeks rehab, and we want to basically line them up to get the best possible outcome that they can. Now, there's another consideration here, is that even if we consider he might just be a type 2 injury, we haven't got the scan results yet to show us anything more. He's got a little bit of prominence, he's certainly got some swelling, and he's got some range of movement restriction. Now, as I said, one of the issues when we look at the literature in our type 1 and 2 injuries is that traditionally they don't have a lot of rehabilitation input. They're just encouraged to get back to what they should do, what they can do. Now, the issue with that, if we follow them up in the longer term, is about 26% of that cohort will end up needing some intervention to their AC joint. So again, maybe we undertreat them? Are there things that could give us better value? Well, if we look at the evidence to give us some clues, then it's probably not any great surprise to know that there is some tentative evidence to support the relevance of scapular-based exercise. And I'll come back to that, because if you've heard me talk before, when's it a scapular exercise, when it's a cuff exercise, basically they do the same things. But certainly interventions that have looked at specifically looking at protraction, retraction, really targeting deltoid, trapezius and serratus, do seem to have some role in patients with persistent symptoms in the longer term where other things have failed. Now, let's take a sensible look at this. If somebody's had some sort of AC joint injury, we as physiotherapists can't impact the ligaments. However, we have this fabulous anatomical arrangement where deltoid and trapezius interdigitate with those ligaments at a deep level, and so are well placed to actually provide some stability to the joint if we can create some solid foundations. We also know that our clavicular rotation is secondary to our scapular upward rotation. So again, it would make sense that if we really emphasize scapular upward rotation and protraction, then potentially we're reinforcing optimal mechanics at the joint. Now, again, I'm very clear that I'm not talking about optimizing biomechanics. What I'm doing is targeting the muscle system that I know has the maximum effect on that joint. Now, interestingly, again, if you look at patients who have AC joint injuries, who have long-term symptoms, there is a small number study that suggests this presence of asymmetry. Well, we know lots of people have asymmetry in their scapula, and they talk about the wonderfully named 6 scapula, which basically stands for scapular malposition, an inferior medial border winging, which just relates to this kind of downward rotation due to that loss of congruence between the clavicle and the AC joint. And remember, an important thing, certainly in your type 1, 2 and 3 injuries, this is not about the clavicle going up, it's actually about the acromion going down, because we lose that strut. So whereas often people do a lot of attention trying to pull the clavicle down, what we need to do is bring the scapula up to it. And if you don't believe me, look at some of the papers and just draw a ruler across, and you'll see that it's acromion that's dropped away. It's only really in those type 5 injuries where it truly, tents the skin, and we have both components in that the acromium's dropped and we've got this superior displacement because of that loss of deltoid trapezial fascia stability. So in terms of back to our 6 scapula, I talked about that malposition, that inferior medial border. C stands for coracoid tenderness, and the K is the K in dyskinesia. So quite, but I just love that sixth scapula. Now again, we have to be really honest. If you've heard me talk about scapular asymmetry before, we have to be very cautious. And if we're honest, the study that looked at this was a small number of patients. However, when we looked at the exercises they used, things like the robbery exercise, which is basically scapular retraction, some external rotation, and almost like a low row. So we know that gives us really good effect in terms of trapezius. Certainly anything that we do in terms of emphasizing retraction. So another thing they included was using the kinetic chain to do what's called a scapular dump. So again, into full protraction combined with some knee flexion, and then pushing back into knee extension and actually retracting the scapula. They also looked at some weight bearing. And again, we know that push up plus, depending on the load they can maintain, has great value in terms of serratus. But if we look at trapezius and some of the and deltoid themselves, basically anything working at 90-90 is an absolute no-brainer, because it gets all the parts of trapezius working, it gets all the parts of deltoid working, and importantly, it also gets your posterior cuff. So you can see a very natural progression there in terms of this kind of protraction and retraction based exercise. And then once they can tolerate it, looking at really augmenting that stability of deltoid and trapezius by actually emphasizing that 90-90 position. Now, the reason I mentioned serratus as well, excuse me, is often these patients lose cross adduction for a short period of time. The joint can get a little bit of stiff, but obviously we need that full protraction movement for serratus to do its job. So again, interestingly, this study that showed a successful intervention looked at doing serratus protraction dynamic hugs, but at lots of different degrees of elevation as the patient was able to progress. Why is that relevant? Because we don't just have one part to serratus, okay? It's a multi-pennate muscle. Some studies suggest 3 functional aspects to serratus, others just 2, but fundamentally we want to be doing that protraction through range. And if you've heard me talk about the kinetic chain before, you'll know that if we initiate our exercises with the kinetic chain, we just make it easier to affect those scapular muscles, those scapular mechanics, if you like, and push that clavicle round more. So that's kind of putting together everything that we currently understand to get the best value from those exercises. And again, targeting serratus would seem to have some value, because if you look at those patients who have long-term problems, who don't perhaps do so well with conservative management, feelings of fatigue, ongoing issues with medial border scapular pain, and cervical spine issues, it's highly correlated with serratus weakness. So really what we're doing is taking the best that we can from the limited evidence that's out there and putting it together in a proactive approach to somebody with an acute injury. I'm trying to kind of optimize foundations in terms of getting the scapula and the cuff doing their job. And a favorite for me in this population is doing something like a wall squat, where essentially the ball or the walls behind the patient, if you like, to give them a scapular assistance as they just do some cuff recruitment through range. Another great exercise for this that again has a good pedigree in terms of its effect on the muscles we're trying to target is the wall slide. So if I put a band around the patient's back and got them just doing a wall slide up the wall, then again, I'm still getting cuff and scapular recruitment, but I'm controlling their plane of movement. And so what the wall slide seems to do, because it keeps it short lever, but also controls the plane of movement, it really seems to foster upward rotation of the scapula. So again, some really simple entry-level exercises. Then we can do those low rows. We can do some low row protraction if they can cope with it. We can even just get them doing the scapular movement if pain won't allow them to do much above 90. But then you can see how easy it is to progress those exercises through range and with load. And again, another thing that was described in this study was the relevance of doing shrugs at end range, but actually holding on to a bar, so using body weight to actually give that effect. But what are we doing if we shrug at end of range? We're just reinforcing trapezius and serratus to get that last bit of upward rotation. So essentially, we're achieving lots of things. We're promoting optimal scapular mechanics, whatever they are. We're just making easier to get the scapula doing its job and take a bit of load off that AC joint. But then on top of that, we're building strength and stability through deltoid and trapezius. So some really simple things that we can do early on. Now, the only word of caution, lots of ideas for exercises and things, but the only slight word of caution If we try and push these people too fast too soon, and that means let them do heavy loads before they've got good range of movement with minimal pain, certainly in terms of elevation and abduction, ideally cross adduction, and able to take some weight through their arm, like pushing up through a chair or even just in a push-up position, if we load them too heavily, too quickly, we run the risk of them developing an osteolysis. So things that are particularly associated with this are protraction loading, like a chest press, or overhead loading, like a shoulder press. Now, you have to be cautious, and it doesn't mean they can't be doing all the other things that we've talked about, because they're actually going to make life easier and potentially improve stability. But what we want to be cautious of is not loading too much on potentially an inflamed joint, as this does seem to potentially relate in an osteolysis, which are kind of stress inflammatory response that results in reabsorption of the lateral end of clavicle. And you really don't want that, because then they're going to be out for a whole lot longer. So with this guy, as you can see, in the first 3 weeks, there's some really simple things that I can get him going in an effort to kind of look at getting him back to play. But for somebody like this who wants to get back to sport, this is where the MR is actually really useful. And what was fascinating when this guy's MR came back is that actually he had a type 4 injury. So remember, it was a type 2 on the X-ray. He had a type 4 on the scan, where his clavicle had actually tented through his deltoid and trapezial fascia, and he'd actually peeled it off a long way down the clavicle. Now, there's lots of surgeons that would still argue that actually, with this guy, if he's improving significantly, then you would still look at how far you can get him with rehab. However, there's a patient at the centre of this, and clearly they're involved in that decision making too. Now, this guy had done all the right things. He actually was improving, but he still had significant movement restriction. And what was key is that when you got him into range, there was this overriding of the clavicle on the acromion. So you remember back to what I was saying about that locked situation. So this guy was unstable. It was blocking his movement. He continued to have pain. And importantly, it was very difficult for us to change things with any of our modification or improving the scapula. So he did actually go on to have surgery. And actually is I'm sure will do very, very well. He's not going to be back for the playoffs though, so I'm not sure anybody's going to be very happy with that. Now, just another quick, I must go soon. I always try and do 15 minutes. I've failed again. But just another thing to share with you, because this just brought to mind another patient that a colleague of mine asked me to review. A guy who'd had supposedly, again, a type 2 injury about 12 months ago, had seemed to do okay with rehab, certainly in his active movements, a bit of end range niggle, but he wasn't too worried about that. But then he'd come back to see her because he was getting progressive medial border scapular pain. He was getting some really anterior coracoid pain, and particularly when his arm was dependent. So if he supported his arm, it wasn't as bad. But if he went for long walks, if he was on his bike for a long period of time, this pain at the front of his shoulder and around the medial border got worse. Now, this colleague of mine is a fantastic physiotherapist, and she'd done all the things that we talked about. He was strong if you tested his individual muscles, but he just couldn't get over this particular issue. Again, he was reviewed by my surgical colleagues, and he ended up having a delayed stabilization. So I think the key thing I'm saying is that bottom line is, one, don't trust x-rays, trust the clinical picture, because the bottom line is 80% of these injuries do well with rehabilitation. But there are some key things we can do to set people up by targeting the muscle system from the outset. We just don't want to go too fast too soon, because we want to avoid an osteolysis. But secondly, in somebody that tells you about a history of an AC joint, who describes this coracoid pain and medial border scapular pain, of course we're going to try rehab first, targeting all the muscles I've talked about. But again, if it's in that dependent position, it's often an indication that they've lost that strut and they can't compensate for it functionally. But again, we're going to rehab first, but just have that at the back of your mind. And this is where working with the MDT can be absolutely invaluable in helping with your decision making. Now, there's been all sorts of pops, so I suspect there will be some questions on here. So I'm just going to have a little look and see what's on here. So the AC joints. Tim, some shoulder surgeons consider it the keystone of the shoulder, although interestingly, most surgeons still use the Weaver-Dunn procedure, which involves excision of the distal end of the AC joint and only reconstructing the superior and inferior joint capsule. Do you think the Weaver-Dunn is still a viable option for those that don't get on with traditional rehab techniques? So from my point of view, actually, Weaver-Dunn has very much gone out of favour, because there is an increased recognition if you have coracoclavicular ligament damage, which is what essentially a Weaver Dunn replaces, it clearly doesn't address the AC joint element of the instability. And this is in the presence of frank ligament damage. So we know that you get an AC joint sprain, then an AC joint ligament tear, then a coracoclavicular ligament tear. And obviously it might be one or both parts of that coracoclavicular ligament are trapezoid or conoid. Now, the big challenges of surgery is recreating that 3D stability of the joint. And I think it's fair to say we probably don't do that, and yet functionally people seem to do well. So the reason we've moved away from the Weaver Dunn is that there are better, arguably, there are better devices out there that have greater load to failure, and also increasing recognition that you need to do something to repair the AC joint ligaments and capsule as well. So I think from my point of view, I don't want to be chopping anything out unless I have to. And really, I want something that's going to give the best stability in the longer term, particularly if somebody is going to return to high load. So Tim, I hope that answers that, but it's very much gone out of favour, certainly with the guys I work with. Sue says, can AC visual instability be a restriction for return to handball? So, Sue, this is where it's so interesting. You can get people, in fact, my husband's a perfect example of this, where you have a very prominent AC joint and yet people have no pain and function. I think rugby players are a classic example of this. So we have lots of conundrums. In fact, when I was preparing for my lecture last Friday, I was reading a few things and it was looking at subgroups, even within those different groups in terms of types of injuries, which bit of the deltoid trapezial fascia. So again, all these things are based on symptoms, and there's absolutely no doubt if you've got somebody with a clavicle that is very prominent, as long as it's not tenting the skin and as long as it's not dangerous and they've got no pain and good movement and they can do everything they want to do, then why could they not return? Because that's suggesting that they have functionally compensated and probably still have some of that deltoid trapezial fascia intact. Clearly, if it's really painful and it's coming through the skin, then that's not going to be terribly helpful. So, Suze, I hope that answers that. Stephen, thank you very much. Louise, brilliant. Thank you very much. Glad that's been useful. So, guys, I've been on here for 25 minutes. Gosh, that's a long one tonight. Now, I did actually do a Facebook Live about, in fact, a whole podcast about the AC joint in February last year. But I wanted to talk particularly about instability tonight and get a bit more specific about the questions themselves because of these couple of patients that have come along. So I really hope you've taken some useful bits from that. I will try, I'm just trying to think what would be useful to post. I'll have a think and see if I think there's any papers that might be useful. But hopefully, even if you just re-listen to this, it'll have given you lots of different ideas. There's some key exercises that I think really set people with an AC joint instability injury up for success, and importantly, what to look out for so we also don't set them up to fail. So I hope you found that useful, guys. As I say, a bit of a long one tonight, but thank you as ever to those of you who've asked your questions. And I won't be here next Monday because I'm actually in France teaching, so I'll be back 2 weeks today at 7 o'clock for more Facebook Live and sharing shoulder knowledge. So don't forget, if there's any key things that you'd like me to talk about, areas that are of particular interest to you, just post them on the Clinical Edge public page and we'll make sure we cover them in a Facebook Live soon. For now, enjoy the rest of your Monday night, and I will very much look forward to being back. Guys, thanks for all these thank yous in the next Facebook Live. Bye for now and enjoy the rest of your week.